Hello, this is Grace Chao. Thank you so much for the opportunity to share our research with you. I'm going to be talking with you today about volume safety relationships for Roux-en-Y gastric bypass patients in the sleeve gastrectomy era. We have no relevant disclosures. Bariatric surgery is a field that is constantly evolving. It has seen great changes in the past, such as the adoption of laparoscopy. One of the most recent changes has been the shift from laparoscopic Roux-en-Y gastric bypass, making up the majority of bariatric surgery procedures, to now laparoscopic sleeve gastrectomy. Since gastric bypass will remain an important bariatric surgery option for many Americans, it's important to know whether we can continue to offer this procedure in a safe manner. It's possible that in the sleeve gastrectomy era, patients who choose Roux-en-Y gastric bypass face an increased risk of adverse outcomes due to changes in surgeon experience. In order to answer this question, we examined the state and patient databases from Florida, Iowa, New York, and Washington. We chose these as 4 large states in different parts of the country. We examined first-time laparoscopic Roux-en-Y gastric bypass cases completed in 2013 and 2015, as these are the years for which there's full 1-year follow-up for bariatric patients in these 4 representative states. This is also the time period when Roux-en-Y gastric bypass shifted from the majority of procedures to the minority of procedures. We utilize a multi-level logistic regression to examine whether surgeons' average yearly gastric bypass volume has an impact on 30-year and 1-year complications, readmissions, reoperations, and revisions. Surgeon volume was examined as a continuous variable, and the surgeon was treated as a random effect to account for clustering of outcomes within surgeons. Patient-level factors included in the model were age, sex, race, auxiliary comorbidities, and year of surgery as fixed effects. Surgeons were included if they completed 10 bariatric procedures or more every year within the study period. From 2013 to 2015, there were 21,925 patients who underwent laparoscopic Roux-en-Y gastric bypass by 208 bariatric surgeons. The median number of gastric bypasses done per surgeon was 88 per year. The distribution was 11 bypasses yearly at the 5th percentile for volume, 20 bypasses at the 10th percentile, 44 bypasses at the 25th percentile, and 162 bypasses at the 75th percentile. At 30 days, patients who underwent bypass surgery with lower volume surgeons were more likely to experience any complication. As seen here, 7% with the 5th percentile for volume or 11 bypasses, and as seen here for 5.6% for the 75th percentile, which represented 162 bypasses. However, there's notably no increased risk of the 2 most feared complications associated with surgical technique, which are hemorrhage and an anastomotic leak. Increasing surgical volume was still associated with decreased risk of unexpected surgical complications, which include things like wound dehiscence and foreign body removal, which was at 0.5%, was at 0.50% at the 44 bypasses per year, compared to 0.34% at 162 bypasses per year. This other complication category includes non-technical complications such as respiratory infections, cardiovascular accidents, urinary tract infections, and pulmonary embolism, which was also significant seen here. Volume did not have significant impact on reoperation rates. And lastly, at 30 days for readmissions, there was a very small difference between surgeons who performed 11 bypasses per year compared to those who performed 162 bypasses per year. Looking at outcomes at 1 year, the risk for any complication was 10.9%, 10.4%, and 8.7% for surgeons who performed 11, 44, and 162 bypasses a year. Of note, again, there was no statistically significant volume effect on complications due to hemorrhage and leak, which again are related and the most serious complications related to technique. As seen with 30-day outcomes, the volume again did not impact the reoperation rates. There was also no significant effect on revisions, which include operations done for failed weight loss or other symptoms after the initial gastric bypass performed. When we look at readmissions, the risk at 1 year did decrease with increasing surgeon bypass volume. Here we see that it's 8.52% at 11 bypasses compared to 6.77% at 162 bypasses per year, with a p-value of 0.004. There are a few limitations with our study. So first, for state and patient databases, these lack precise clinical characteristics of comorbidities. Of comorbidities, complications, reoperations, revisions, and readmissions. So we're unable to determine the severity and clinical nuances of each of these outcomes. For example, we were unable to assess for internal hernia due to the inability of the data to show us that. And sleeve gastrectomy is also still a relatively new procedure, and thus 1 year full follow-up time was consistently available for analysis only from 2013 to 2015 in our study. But despite these limitations, these data allow us to draw from multiple states, examine the most diverse patient population by including multiple payers, and the ability to track patients' long-term outcomes. In summary, our multi-level logistic regression revealed that patients of surgeons that have lower gastric bypass volumes had only a small increased risk of 30-day complication rates and any 1 year complication in readmission. The volume effects of complications and reoperations due to hemorrhage and leak, which are the most feared complications related to surgical technique, were not statistically significant. This is the first study to examine the effect of surgeon gastric bypass volume on patient outcomes as the national experience with gastric bypass diminishes. Overall, there are very little differences in clinical outcomes after gastric bypass, regardless of surgeon volume. Thus, patients can safely pursue gastric bypass in this early phase of the sleeve gastrectomy era. I'd like to thank my mentors, Dr. Dimick, Dr. Tellum, and Dr. Chabra, and for my teammates, Dr. Yang and Jyoti Thoma, who have taught me so much through this process. I'd also like to thank the National Clinician Scholars Program and the Veterans Affairs of Ann Arbor for supporting my research. Thank you again for your time, and I'd love to hear from you if you have any feedback on our project and any other recommendations. Here's my email address, and you can also find me on Twitter. Thank you again for your time.